Let me know if you can see my screen.
Yes, we
Yes,
can.
you can.
Excellent. Okay. So let me
Okay.
start in presenter mode.
Mm.
Okay. You can see?
Uh,
Yeah.
yes, so we're good to go.
Okay.
Mm.
Good afternoon, ladies and gentlemen. You're welcome to the second edition of the Society for Information Science and Technology series of webinars holding today, Saturday, 22nd of June, 2024. We have an interesting presentation today, but before we get started, I'd like to call on my co-moderator, Dr. Lola Omotayo, to please introduce our guest. Dr. Omotayo, over to you.
Okay, thank you, everyone. I again welcome everyone to this second edition of the Society for Information Science and Technology of Nigeria webinar 60 in short. Actually, we're supposed to have two guest lecturers, but fortunately, one of them could not join us because of the exigency of work. But very gladly, we have Dr. Rosemary Agbolaho with us. Dr. Rosemary is a program manager at Clinical IT Shared Services, New York Presbyterian Hospital, USA. And she's a proud alumnus of UI. Yeah, proud alumnus of AKIS, then, and UI. She actually taught in the department for more than 10 years before she relocated. So she will be giving us a lecture on medical records management in America, lessons for Nigeria. So I heartily welcome Dr. Rosemary Agbolaho. You're
Thank
welcome,
you.
ma.
Thank you very much. All right. Let me know when you want me to start.
Please go ahead. You have the
Go
All
floor.
right. Thank you very much. And I'm grateful for this opportunity. It's been a while since I saw people from AKIS, since I spoke to people from AKIS. I think the last time was at Professor Tiamiu's retirement. And I want to thank you all for all you are doing. I know it's now called Department of what? Information and something. I don't know what the new name is.
Data and information.
Data and information. I always remember it as AKIS because I was a student and I like they said I taught there for I think about 12 years. So thank you all for this honor and this privilege. I appreciate it, and I appreciate all the work that you are doing. So let's just dive right in. What we're going to be talking about today is medical records management in America, and we'll talk about some lessons for Nigeria. So I'll just go ahead and this is an overview of what we'll talk about this afternoon. We'll talk about medical records, what's a medical records management. We'll talk about electronic health records, electronic medical records. We'll look at the lessons from the USA in terms of access, ownership, privacy, and interoperability. There's a lot of lessons, but I just wanted to just pick four. So what is medical records and medical records management? So a medical record is a record of a patient's medical information, things like their medical history, the care or the treatment that they have received at a clinic, at a hospital, things like test results, diagnosis, any medications they take. These are all part of the patient's medical record. So traditionally, this was stored on paper. Somebody will bring a file and all of that. I think it still happens in a lot of places today, even in the USA. But more and more all this is being transitioned to electronic storage. So the medical record is put in an electronic medium, transitions from paper. And what is medical records management? Because that's our focus. So our medical records management includes everything connected to the creation, the use, the handling, the disposal of patient records, So from the time it is created to the time it is disposed of, everything in between is medical records management. And this includes both physical, paper records and electronic records. So paper records on DVDs, on CDs, if such things still exist, and then, electronic records. So as soon as a record is created, there is something in place to make sure it is appropriately handled until the time it is disposed of. So in the United States, when we're talking about lessons from the US, in the United States, there's a complex systems of rules and regulation regarding the life cycle of a record. You know, for example, I live in New York. In New York State, medical records are to be retained in their original state. So if they were obtained on paper, they are to be retained in their original state or in a legally reproducible form of their original state for at least 6 years from the date the patient was discharged. So if the patient was admitted in hospital, was in hospital for a month, for example, and then they were discharged, the statute of limitations in New York State states that 6 years from the date that that patient was discharged, any record that is called for should be produced in the form in which it was recorded or in a legible production of that original record. So if the pediatrician wrote notes on paper for 6 years, we should be able to get those paper records. If they documented in, let's say, an electronic record management system for 6 years, we should be able to ask and instantly it should be produced. All right. Now, state laws, they differ. In the US, one thing is that states make their own legislation. There are federal legislations that are umbrella, but states also make their own legislation, their own laws. Many times state laws are more stringent than federal laws. So the federal law is a guideline, but the state now comes to the nitty-gritty, what you can do. For example, in some states, up to the age of 21, you should be able to produce the birth record for a child. So that's the record of the labor and delivery. You keep it up till that child turns 21. They can ask for those records. Anything can happen. So we talk about, now let's talk about records management, medical records management. Now, medical records management, generally, the concept of medical records management, we've talked about that. Why is it important? It's important because well-kept medical records make life easier for the healthcare provider. You know, they make life easier for the patient. So having a comprehensive overview, having a comprehensive view of a patient's medical record or patient's medical history makes it easier to provide care. So if I'm the patient's primary doctor, and before the patient came to me, the patient was seeing some other doctor at another state, having the patient's medical record in a legible form makes it easier for me to know, okay, what happened, what didn't happen. Suppose I was treating an elderly patient that had dementia. The patient can't remember anything, you know, or they remember some things and don't remember other things. But I need the patient's medical record in order to provide appropriate care. So having the medical records well in a form that is legible, in a form that is accessible, makes it easier for me to provide appropriate care for that patient. It's also for the safety of the patient. It's also
Doctor, sorry for cutting in. The slides are not changing.
Yes.
My what?
The slides.
Yeah.
The slides.
No, I'm not. I didn't. It's just. I will change it when I talk.
Okay, good. Okay. Sorry.
All right. So I'm just. Let me just give you a heads up. In here, we don't put a lot of text on slides. So if you need the text, I can provide the text after. We don't put text on slides. What you will see will be pictures, and I will speak to the pictures.
Okay.
All right.
Okay. Please go ahead.
So having up-to-date records can be the difference between life and death. I give you an example. My elder sister, she's allergic to penicillin. She's very, very allergic to penicillin. One time in Nigeria, many, many years ago, before she was even married and had children, she was sick and it was some kind of infection. And so that they took her to hospital. And what did they do? The first thing they did was give her penicillin. She almost died. Her body erupted. In fact, till today, you can still see some some bumps on her body. She erupted. It was terrible. Thank God there were doctors who were knowledgeable and were able to treat her. All right. Now, if we had a comprehensive, told her regular doctor that she sees, that one already knows that she's allergic to penicillin. But she went to the hospital. It was an emergency. They didn't have any clue to this person. She couldn't talk. She was so sick. They didn't know that she's allergic. So after the whole thing, when she was discharged, on her paper, I saw her paper file folder in the hospital. They wrote big bold letters, SOHA is allergic to penicillin. That's paper. But suppose she goes somewhere else. She travels and has to go somewhere else. Who has that record to say this patient is allergic to penicillin? So that's the importance of medical records management. Now, coming down to electronic health records and electronic medical records. In recent years, the US has transitioned from paper to digital record keeping. What was it? How did we achieve that? Now, in many places, there's still paper. I'm not saying it's 100%, but for the most part, it's electronic. How did the government achieve this? To do this, what they did was to incentivize the transition to an electronic health record. Give providers money, incentive payments. Okay, if you document up to 80% of all your visits, patient interactions in an electronic health record system that we can query, that we can produce reports from, we will give you X amount. So they did that, and a lot of providers transitioned. And once the incentive payments stopped, so there was, a couple of years for incentives. So between this time and this time, you will get money. Once those incentive payments stopped, the providers who were now used to using electronic health record found it difficult to go back to paper. Because now, at the touch of a button, they can see, okay, this was the last time I saw this child. It was here for blood work. We did this. We found that, oh, he needed to get more iron. He needed to get vitamin D. So going back to their paper system where they have to now scroll through everything was more difficult for them. So most organizations, most doctors' offices, they have electronic records. Some still have paper. It's not a one-size-fits all. So in the last couple of years, the healthcare industry in the United States has transitioned from paper to digital record keeping by hospitals, by clinics, nursing facilities, etc. So the federal government also, like I said, invested billions of dollars to fund the hardware, the software, the training, because it was not just enough to get the hardware and the software. People also needed to be trained. So the government actually sponsored that. So talking in terms of lessons learned, those are some of the things we can pick from there. So what is an electronic medical record? It is a single, it's a digital version of a patient's chart, and it's usually owned just by a single practice. So a single clinic, a single doctor's office. That's an electronic medical record. It's usually for just one location. So it's all the patient's medical history, diagnosis, everything we expect, but usually it's just by a particular physician, a particular doctor's office. Now, what is an electronic health record? An electronic health record is just like the medical record, is also a digital version of a patient's chart, but it's more inclusive. It's more inclusive, So health records are designed to be shared with other providers. Medical record is just for this office. If I want to share it, most times they'll print it or they'll write it on DVD and give me to take to the other office. But if it's a health record, it's more inclusive. So it's the medical records, the lab work, the provider's notes, everything about my care in that organization, and it can be electronically shared with other organizations. So the EHRs, the electronic health record, they serve as a centralized location for healthcare providers to get increased accessibility, and we will talk about access. So benefits of EHR. The benefits include more streamlined sharing of patients' record, more streamlined sharing, a complete medical history. So you have the patient's lab work, you have the patient's dental records, you have the patient's allergies, their immunizations, the medical notes, all of it in one space. So more and more in the United States, we have more organizations use electronic health records. Electronic health records tend to be big, widely used by different organizations. So my organization uses one particular type of electronic health record. It's the same that is used by different hospitals in the city, in the state, even in other countries use the same. So because we use the same type of electronic health record, we can more easily share patients. So if my patient goes to Canada, for example, and goes to a clinic in Canada, the clinic in Canada can ask my hospital to say, look, your patient is here. We want to see their allergies, they are this, they are that. And we can send it as they're on the phone. I press a button and they get it in Canada. So those are the benefits of electronic health records. So both electronic health records, electronic medical records provide better benefits. They offer better benefits to both the patients and the healthcare providers. They're faster, the charts are more complete, they are clearer, there's more improved information access. Patients can participate in their own care, and we'll talk about that in a little bit. And we'll have questions in a little bit. So now, I give something about clarity of medical records. One time, I remember I went to this, my physician was still writing on paper then, the physician I was seeing. And physicians are doctors. So in the US, we call physicians doctors. Well, we call doctors physicians the same way. So the physician I was seeing then, he wrote a prescription for me. And I looked at the prescription and I said, you really went to medical school. He started laughing. He said, why? I can't read. I can't understand what you are writing. You just wrote something and gave to me to go give the pharmacy. It was like he wrote in Chinese. I did not understand it. I took it to the pharmacy. The pharmacist looked at it and said, do you have your doctor's number? I gave him. The pharmacist called the doctor to say, what exactly did you want me to give this patient? Because he could not read it. And this is real life experience. So those are part of the things, the advantage of electronic medical records. So we've talked about a few lessons. We've hinted at a few lessons. The government incentivizes by giving the providers and organizations funding to install or implement electronic medical records. But it wasn't just giving them money, it was setting standards. The electronic medical record that you install or that you implement must meet certain standards. We must be able to query it. It must be able to share records with other organizations. It must be, able to give the patient access to their records. So there were standards that were set. So it wasn't just giving money. And then aside from implementing the electronic health record system, you have to use it for X number of your visits. And, then they will check and run reports before they gave them incentive payments. So that's one of the lessons. Now, more specifically, I'm going to look at four takeaways from the experience in the USA. One is access. So enabling access and preventing access, and allowing authorized access, preventing unauthorized access. So that's a core thing for electronic health records. We have all heard of AI. We have all heard of hacking, unauthorized access, where, and in the last couple of years, hospitals have had to tighten their information infrastructure. We never thought it would get to a day where a hacker would take over a hospital's health system and say, unless you pay me X million in Bitcoins, I will not allow you. So they locked it down. Providers could not log in, health people could not log in, patients could not log in, the billing folks could not log in. The hospital was losing money. In the end, the hospital had to pay the hackers in Bitcoin so that they can unlock their health systems. A number of health systems suffered that. After the lessons from those health systems, in my organization, for example, our information security is an entire unit, and they are locking down things, passwords. Your password, our passwords are at least 13 characters. So you don't use like a password. Now we use like passphrases. Your password is almost a paragraph, and more security infrastructure. So access is a big thing. So access is allowing authorized access, preventing unauthorized access. Now, in terms of the lesson from access, it's also in terms of patients being able to access their medical records. A while back, patients will have to, if a patient needed their medical records, they will have to, go to the medical records department, they'll fill a form, they'll wait like a week or two, and then they'll come back and pick the paper record. In recent times, that has changed significantly. The patient can call the medical records department now, let's just say, even my small personal private provider has an electronic health record system, and I have access. So if I have an appointment that is due, I will see it. I'll get an alert from the office to say, oh, you have an appointment, or your lab results have come in. The only thing I can't see for that particular doctor is her notes, but access means that now, instead of going to medical records and filling a form and doing that, patients have access to their medical records. In fact, many times, some of the providers I work with have complained that they're in the office. So the patient comes, I work with emergency providers. The patient comes, they do some blood work, the results come, and the lab sends it up to the patient's portal. So while patient is waiting to see the doctor for the result, the patient opens their portal. Oh, the lab is here, and the patient sees the lab results. Doctor comes back into the office and patient says, I see, what does this thing mean? What does this thing mean? And the doctor hasn't even looked at the results. So sometimes our doctors complain that the patients see the results before they get a chance to explain to them what those things mean. But in the US, patients now, the move is now to allow patients to access their records, so that when providers write things, they write it in patient-friendly terms. They write it in what we call patient-friendly, so that patients are able to understand what this thing means. So basically, they can have access to everything except, reading their doctor's notes. But even that is changing. An organization called Open Notes, they have been pushing a movement that encourages full access to the doctor's notes. And in my organization, we have implemented Open Notes so that patients can see even the notes that were written by their doctor. The only thing that are restricted are like psych notes, psychiatric, mental health, behavioral health notes, because sometimes some of the things that are written there might be triggering to the patient. So those are still, the access to that is still limited, but access to every other kind of note is the move now is to allow patients to see their notes. So after a patient's visit, once the provider signs the notes electronically, it goes to the patient portal, and patient can see everything, can see the labs, can see the notes that were written by the provider, can see the test, can see interpretation, and all of that. Now, some providers are concerned that allowing patients to have full access may be detrimental, that they may spend a greater time of their time with the patient, explaining what all those things are. But others have said, and then studies have been done that other providers have said that, allowing patients to have full access makes for better care because the patient now is a more informed participant in their care. So they can see that, okay, if you do this, you will get this. If you don't do this, and they can see it. So they are now a more informed participant in their care. So access is allowing more patients to, get access to their medical records and without much trouble. And also, access is allowing the medical records to be shared with people that need it. So, for example, if I am sending my patient to see a specialist, such maybe a heart specialist, I should be able to allow that heart specialist to see everything that I have written about the patient so that the heart specialist has a full picture of what's going on with the patient. I know this is a lot, but we will have questions in a little bit. Another issue I want to look at is ownership. Now, ownership is an ongoing debate. Who owns the medical records? We've established that patients should be allowed to access their records. There are laws, there are legislation that are, guaranteed that patients should be allowed to access their records, see their records whenever they want. Now, the problem is who owns those records? Because when it was on paper, it's the doctor's office or the hospital or whatever medical record department that owns that paper. The patient owns the content. The hospital owns the paper. Now it's no longer on paper, it's digital. So there's an ongoing debate. Now, the thing in the US is that there's no federal legislation about ownership. There's no federal legislation about who owns the medical record. So states have come up with their different legislation. Now, most states, it's still like 50-50. Most states lean towards the hospital or the doctor's office or the clinic. They own the medical record as long as patient can access it at any time. However, one state in the US, New Hampshire, explicitly gives ownership to patients. They say the patient owns the record. You cannot do anything with it without the patient's permission. So New Hampshire explicitly says the patient owns their medical records. Other states are like, yeah, okay, it's the person who generates the records. Now, why ownership important? It has legal implications. So ownership implies a legal right to have, to use, or to dispose of. So to have, to use, to dispose of. Now, in the context of healthcare, there are ethical considerations. And I'll tell you what happened recently. My organization is part of a larger network of organizations. We share information. Now, the code of conduct concerning sharing is that we are organization A, we share with B, B also shares with us. So our patient comes here for their regular care. Our patient goes to organization B for their cardiac care, for their heart issues. So if we send information about their OB, obstetrics, their GY is a female patient, there are female reproductive issues, reproductive health, we send information to an organization B. B should be sending us all the information about their cardiac care and everybody in this network who shares patients, because we share patients. In the US, there's a lot of specialization. For example, I tell you, if I go to a dentist, my regular dentist for a cleaning, if I need a tooth extracted, or they need to do something on a tooth, they send me to a specialist. So the person who cleans my teeth is not the person who will extract the tooth. The most that guy will do is clean the teeth, and if there's a cavity, fill it. If something needs to be extracted, that's surgery. They send you to a dental surgeon So there's a lot of specialization in the US. So you can have one patient who is seeing like 4 different specialists, depending on whatever their medical conditions are. Now, the thing with records is that we are all expected to share. All of a sudden, we find out that we are sharing with B. B is not sending any information back. So we send our patient to you. You are pulling our patient information. You are not sending us information back about this patient. What happened? We kicked that guy out of the network. They kicked that organization out of the network because there was suspicion that they were accessing patient records for something else other than treatment. So they removed that organization from the network. So owning a record has ethical considerations. It has considerations about patient rights. So if you are accessing the record, it doesn't mean you can do anything you like with it at any time. So ownership also has elements of control, controlling what happens to the record. So the debate is still on. In the US, there's no consensus about, aside from New Hampshire's, that says explicitly the patient has ownership, the patient determines what happens to their records. For many other organizations, for many other states, is, well, the ownership is still partly patient, partly the hospital or the organization. And in some, they say, okay, we need authorization from the patient in order to, do something else with the record. And the third thing we will talk about is privacy. Privacy. We all heard of, and we talked about it, we talked about hacking. With the increasing digitization of medical records, protecting patient privacy has become very challenging. Very challenging. Patients have the right to expect that their sensitive information is safeguarded against unauthorized access. Patients have that right. Now, technology offers benefits, but technology is also easy to manipulate. It poses challenges in terms of privacy, in terms of ethics, in terms of, who gets this information and what they do with it. So there is that balance. We have to balance access with privacy. So in the US, a couple of years ago, many years ago, the US developed what we call the Health Insurance Privacy and Health Insurance Portability and Accountability Act. It's called HIPAA. Now, what this act does is to emphasize the protection and confidentiality of patient health information. In some, the only information you should get from a patient is the minimum required information. Minimum required information. So, for example, in a waiting room for a hospital, I cannot be asking the person who is, registering the patient. All you need is the patient name, the date of birth, and the address. You cannot be asking the patient, you who are a registrar, clerk registering the patient, why are you here? You were here last week, why are you here again? That is not your business. There are 12 other patients in the waiting room. You should not be asking the patient, why are you here? The nurse who is triaging the patient should take the patient away from that 12 people and then can ask the patient, okay, Mr. Jones, what can we do for you today? Why are you here today? Without other patients overhearing the conversation. So the HIPAA Act means that if you are in an elevator, in a lift, you should not be saying, did you know that that woman, this one and the other one, other patients. So that act actually puts in monetary consequences. So if an organization, if an employee or a contractor in an organization discloses patient information in a unsafe space, and there's a report, the HIPAA Act allows the organization to be fined. There's a fine running to hundreds of thousands, sometimes millions of dollars for breach. So every employee in the healthcare gets a HIPAA training every year, once a year. So when you come in as a brand new employee, you do a comprehensive training. Then every year we do a refresher training. It's required. There's mandatory refresher training to remember that, you don't allow someone log into your computer, give somebody your password. You don't go and open a patient's chart when you don't have any business there. We had occasions where some celebrities were seen at some hospitals in the US, and nurses who were not on that floor went to open the patient's chart. I hear that XYZ, she came here to have a baby. And some nurses who were not on the patient floor, who had no direct care for the patient, they went to open the chart to see, it's actually this person. And they were fired, they lost their job. So with the HIPAA, it's ensuring protection and confidentiality of patient health information. So unlike rules governing ownership, HIPAA establishes national standards to protect individual medical record, and what we call PHI, personally identifiable information. Personally identifiable health information. So for example, if I'm writing an email to somebody, I cannot put the patient's medical record number. I cannot put the patient's name. I cannot put the patient's address or date. Anything that will identify the patient should not be in the email. If I need to send it to somebody, I should do it in a secure server that the person I'm sending to will have to log in to access the information that I've sent. So HIPAA requires appropriate safeguards and sets the standards for protecting sensitive information. All right, lastly, we're going to talk about interoperability. Now, in a health system that is complex, we use diverse health records products. We use a product for labs. We use a product for pathology, for specimens. We use a product for ophthalmology. We use products for GI, colonoscopies, all those, doing intestinal investigations. We use products in the emergency room. We use products for MRIs, for X-rays. All of these things need to talk to each other. And that's where interoperability come in. So with interoperability, there are standards that are set so that different kinds of systems that deal with the patient healthcare can talk to each other. They talk to each other so that, we can get timely information, secure information, integrate all the different bits of information, and be able to provide more comprehensive and safe care to patients. And I underline the thing that interoperability improves the delivery of healthcare by making the right data available at the right time to the right people. I know we learned something like that in our case. Making the right data available at the right time to the right people. So my patient goes to get an X-ray. I should be able to see it when I'm pulling up the patient's electronic record. I can see the picture of the X-ray. I can see the interpretation by the radiologist. I can see all that without having to live there. I can access all these things. They all talk to each other. So in EHR interoperability enables better workflows, reduced ambiguity, allows data transfer among different systems and stakeholders. So, and this is particularly critical in these days where everything is electronic. So, and one thing about interoperability, the COVID-19 pandemic showed us in a big way in the US. It exposed gaps it exposed gaps in our infrastructure, that a patient came in with COVID and they couldn't talk, they couldn't breathe, they couldn't tell us about their allergies, they couldn't tell us what was going on with them. We know that this patient is COVID positive. So we are doing things, we are trying to take care of this patient, but we don't have enough picture. We don't know if this patient has comorbidities. In a comorbidities, things like, okay, this patient is here, are they diabetic? Are they hypertensive? Are they immunosuppressed? Do they have some other kind of disease that suppresses their immune system? We are just trying to manage COVID. But then if we have access to their other healthcare, we can see, okay, this patient has COVID, we are treating COVID, but this patient is also hypertensive. This patient is also diabetic. This patient has a history of high blood pressure, so we can manage everything together. And since the COVID pandemic, a lot of work has been ongoing in the US to ensure that our systems are more interoperable. So for a place like Nigeria, where I would say electronic health records management is still in its infancy, these are all lessons that we can take away. These are all things that we can begin to look at. There is a lot to learn, but also, and every environment, I've talked about, in terms of ownership, even in the US, they have not come up with a federal legislation. So every environment has its own unique challenges. I know a lot of challenges in Nigeria has to do with infrastructure and a lot of things, but there is no need to start from scratch. There is no need to make the mistakes that all other more developed nations have made. There is no need. There is a lot we can learn. And, we can learn from the challenges and experiences of the USA, of other countries, and we can get a jump start on, better, more efficient medical records management. We call it leapfrogging, jumping several stages in the evolution and going much more ahead, because you can see that, okay, this didn't work for this person, this didn't work for this person, this didn't work for this person, but it worked for this country, and we can take advantage of those experiences. All right, I will stop here and we can go to questions.
Okay, our time is fast spent. Thank you very much,
I'm
Madam.
sorry, I apologize for taking your time. But you told me that I'm the only person.
Yeah, we enjoyed your presentation, Madam. We're not complaining at all. So I think we have time for about 2 or 3 questions. So members of the audience, please, if you have a question, just raise up your hand, use the app so that we can call you and you tell us what your question is. Thank you. Questions, please. Hello? Since there are no questions for now, but I have a question, Madam.
It looks
In
like
lieu of any
people are
other
raising
person,
their hands.
I can't see them.
Sunday to me be Azai Agbonifo
Okay,
and somebody else.
Okay, I can
All
see.
right.
Charles, please go ahead.
All right, thank you very much. Can you hear me?
Please go ahead, Charles.
Yes.
All right, please. I just wanted to ask what role did the private sector play in helping the US government or helping build and also maintain and manage this infrastructure that is currently operational in the US? Thank you.
Okay. Just to say, almost everything in the US is privatized. So when I talk about government giving incentives, they were giving incentive to private clinics, private practices, private hospitals. It's privatized. So any advances that we are seeing in healthcare in the US, a lot of it is from the private sector. What the government does is to set standards. So the government defines standards of interoperability, standards of access, of privacy. So the good thing and the bad thing about private sector is that, you know, it allows different people to develop different things, but then it means that we have all these different systems and they are not talking together. So this government is setting standards. Okay, you have to talk to each other. We're putting in this policy, we are putting this thing, find a way, talk to each other.
Thank you, madam. Next question, please. Do we still have to maybe on? Okay.
James Nana. Okay.
James Nana.
Okay, hello. Can you hear me?
Yes, James.
It's quite interesting hearing you, Doctor. It's been a while. I want to thank you for showing up. During your presentation, and even as you were rounding up, you made mention of the fact that, you know, applying this to third world countries, just like Nigeria, taking Nigeria specifically as an example, and you said that we do not need to reinvent the wheel or start from scratch. In your own opinion, where is Nigeria? Where are we in this ecosystem, in this health informatics or health information, you know, management, in your own opinion? Thank you.
You know, honestly, I've been away for a long time and I don't want to judge. I have seen my elder sister, we lost her like 2 years ago. And before she passed, I was impressed that the hospital where she went to, they were able to, you know, pull her records. They were able to do things on time, but it was a ton of money. It was a boatload of money that we paid for her to get that care. So I have seen some private hospitals in Nigeria being, you know, at the cutting edge of you know, health information management. But then I have seen that they are developing systems that are not talking to each other. It's kind of what the US went through. And that's part of my thing. You don't need to. People are still like proprietary, you know. I don't want to share my patient's information with somebody else in case they take this information. So money still seems to be at the incentive. It's an incentive for everybody, but the first incentive should be providing comprehensive patient care. Where Nigeria stands in this spectrum, I don't think I'm in the best position to judge, because I have seen some good, but I've seen a lot of bad. So, yeah.
Okay, Professor Tiamiyu. So, sorry, Mr. Tumibi. You'll be the second to the last. I'll be the last. You only take 3 more questions. Professor Tiamiyu, please go ahead. Prof.
I think Prof is still muted.
Okay, in lieu of some, Tumibi, can you please go ahead before Prof? I think it's
thank you so much, Doctor, for the presentation. I so much enjoy your presentation.
Please make it snappy.
But there is little injury that I've noticed here in Nigeria. I don't know. Are you hearing me, sir?
Yes, I can hear you.
Okay.
Are you also hearing me?
Yes,
Please
Prof.
go ahead. Please go ahead.
Okay, let Tumibi finish his contribution. Then I will join.
Okay.
I'll off my
Okay,
mic
sir.
now.
So yeah, okay, sir. So here in Nigeria, I noticed that we have EMR operating in some of our clinics. Like you rightly said, most of them private hospitals. But I've also noticed a major issue here. What you get to see with EMR in a certain hospital in Ibadan can be different from what you see with EMR in a certain hospital in Lagos or Abeokuta. We have one also here in Lee City University. But I've noticed this difference in the way they operate. Now, some of them will be so detailed with what they are offering, some of them not so detailed, and you'll be wondering, what can we do about the standard? It's as if different vendors here are designing different kind of EMR. Then with respect to EHR now that you mentioned, I think in our own case in Nigeria, so many people don't visit the hospitals. So many people get their drugs from chemists, pharmacists, and all of that. So if you're doing that in Nigeria, how do you get a proper record of the patient? Because if a patient will only visit the hospital when there is something so serious, apart from that, get the regular stuff from chemists and all of that, then it becomes difficult to integrate the record of that patient. So I don't know, what do you think we can do better in Nigeria to address that?
Well, just like I said before, it happens in the US, and what the government did was begin to set standards. So even pharmacy records now are integrated in the EMR, because when the patient goes to a pharmacy, even the small, what we call mom and pop pharmacy, they are connected to some kind of health exchange. They have to document what the patient took. So somehow, if the patient comes to a bigger hospital, we are able to see that this patient got this prescription from this pharmacy. So it was the government put their foot down and began to set standards, that these are the standards for integration. You have to do it.
Okay, thank you, madam. Professor Tiamiyu, please. Professor Tiamiyu.
Good evening,
Yes.
everybody.
Good evening, Prof.
It's so nice to hear your voice, Rosemary.
Thank you, sir.
I hope you are doing very well in the US.
I am by God's grace.
Okay. And greetings to everybody who are present this evening in Nigeria. I know it's more like 12 noon thereabout in the US. My question is probably more related to information science generally than to EMR, which is the focus of this webinar. And I would like you, Doc, to just shed some light for our benefit on the issue of AI. First, I want you to really say something about AI in the EMR, how AI is being used in EMR in the United States, various EMI products that are on the scene these days, how AI is featuring in them. Then secondly, AI and the curricula of information science education. Because I can see that AI has made so much inroad into various key information science subjects like information retrieval, data organization, and all that, and so on and so forth. So I also want you to speak on how that is affecting information science education curricula in the United States, and what we in the DDIS now should be strategizing towards in order not to be left behind. I hope you have understood my questions.
Yes, sir. And
Okay.
I think to answer your questions fully, we probably need another seminar. But I will try. I'll try. Okay, so now just going by the experiences at my organization, in healthcare, AI is beginning. One thing about AI is that AI needs a lot of data to learn. For an AI to be fully operational, it needs training. So an AI like ChatGPT, the reason why it's able to become successful is that it has the whole of the internet to learn, to train. So AI is training, it's learning, it's a learning algorithm. So now for healthcare, where we are seeing AI beginning to make inroads is in notes, helping providers automatically generate notes based on the interaction between the doctor and the patient and write notes. And so in my organization, we have some pilot projects to train AI to automatically generate notes, medical notes based on the interaction between the provider and the patient. So instead of the provider sitting at the computer and typing away while talking to the patient, the provider can actually, have the interaction with the patient, have that conversation, and then the algorithm is learning, and it's able to generate notes based on that conversation. So in the terms of medicine, I'm seeing AI in note writing, because note writing is one area that takes providers a lot of time. The other areas are, developing things like algorithms, scoring systems, scoring tools, for example, to be able to, based on, a patient's vital signs, labs, all that, and say this patient is potentially septic. This patient is going into septic shock, and be able to alert a provider. So those are some of the areas. It's not so wide, it's being used in limited ways, but we are looking at areas where it can have more impact and where we can train AI to be more useful. So in healthcare, we are looking at those. There are more areas coming up, but it's still in early stages. Now, in terms of the curriculum, to be very honest, I have seen some, just a few trainings here and there. I have not really taken a deep dive into the curriculum of the informatics and information science programs to see which area they are, how they are modifying the curriculum to reflect AI. That sounds like a good topic for research, and it's something I will want to look into a little bit more.
Okay, thank you very much. I think that's good. Yeah, thank you very much.
Thank you, madam, for the answers. I have a question. Still talking about research. Medical records are also used for research purposes, especially in the areas of big data analytics. Oncologists gather medical information of cancer patients to develop algorithms for predictive purposes to predict the best treatment. My question is, talking about federated data governance, what are the rules in place for the use of medical records, patients' record for research purposes? How does it work in the US?
Now, in the US, using patient records for research requires explicit consent from the patient. So that was, I gave the example of one organization that was kicked out of the network because we suspected that they were not using the information for treatment, but for research. They were kind of like gathering the information for treatment. And in these days of AI, we are finding that most because AI feeds on data, it needs a lot of data. So we have
neural networks,
organizations that are illegally, connecting to other networks just to harness data to train their AI. So, but in the US, the rule is that you cannot enroll a patient in, giving a bad history. We have had history with the way the syphilis trials with Black men and all that kind of thing. So we have those bad history. And so the rule is that you cannot use the patient's data for research without the patient's consent, even if it is a diseased patient. It's either the patient gave consent while they were still alive, or a family member who is a healthcare proxy has to give, permission. So that has to give authorization. So that's the rule in the US. It doesn't mean that everybody follows the rule, but that's the rule.
Wow, that's a lot. I wonder how you can get records of thousands of people to train for a neural network, for instance. Let me call on a professor.
You can, like in a place like New York, is heavily dense with patients. So the people who train the AI have to go through institutional review board, the research boards, and all of that to, and all that. And a lot of this is done on a pilot mode before they do. And then when patients present at the clinic, we ask them, are you interested? And they sign a consent.
Okay, thank you. Professor Latoko, please go ahead with your question.
Okay, thank you very much. Good evening, everybody in the house. It's a privilege listening to Dr. Agbola. For information of people in the house, the two of us entered our department the same day in 1997. So it's a pleasure listening to you, Doctor. So you have
I think your network is breaking up.
Hear me now.
Prof, go ahead. You are back on.
Okay, I said you are presented to us a very beautiful lecture. You took us to like an Eldorado, a world where things work. You know, in the Nigerian system, we all know that we know our challenges and we know issue about infrastructure, no integrated system. I want you to maybe, as we round off this evening, what lessons do you think holistically you want to advise us here in Nigeria? There is problem of attitude of people don't go to hospital. How do we now get the data of such people? So what advice do you have for us in the Nigerian health system so that we know that something we can take home, which we can now go and sleep over and see how to implement in our own part of the world? Thank you.
Okay. Thank you. Good question. I remember when was it Dora Kinyuli? She was in NAFDAC, right? And she so streamlined NAFDAC that when you buy medication, you could scan the barcode and it will tell you whether this was genuine or not genuine. I think if we could do that at that level, we could start from the pharmacists. I told you in the US, in the pharmacies, the information they get from pharmacies, we get in the hospital. So even if people don't go to hospitals per se, they go to pharmacies. Is it possible to start the networking and information gathering from the level of the pharmacies? Because if I still remember buying what's the thing they used to treat malaria, and they said, oh, if you put the barcode into your phone, it will tell you whether that was genuine or not. And I was impressed, because I think if we could do that at that level, there is hope that we could do more.
Thank you, ma'am.
Thank you very much, madam. For record purposes, Dr. Agbola supervised my master's thesis at Akis, and it was fun working under. I remember always troubling our son Usama. Forgive me, I used to call her Usama in those days. I was the Akis editor in Chivakista Press. So I wrote an article about Usama bin Laden, and I called him. I was very naughty in those. I'm still a bit naughty now, don't mind, it's just my nature. So we became friends, Osama and I, sort of. So thank you very much, madam, for your time. We are most grateful for the presentation. It's been most enlightening and thought-provoking. We hope that our authorities will do something about it. I'll now call on Dr. Motayo to give the vote of start so that we can round up the program. Thank you again, once again, madam.
Thank you. I appreciate the honor.
Good evening, everyone. Thank you once again. You all agree with me that we've had a very exciting time with Dr. Agbola. The lecture was thought-provoking. In fact, as she was talking, I was thinking of what can we do in Nigeria. So I want to sincerely appreciate you for your time, the time you devoted to prepare this, and the time you have spent to present this. Thank you so much. And I thank everyone that's online. Thank you for putting us in mind, and thank you for joining this. And I believe that you have actually gained a lot. The time you spent have not been a waste. Thank you so much. And I wish that next time you will still find time to join us. Thank you, everyone.
Thank you. Thank you.
See you again in August.
I have my notes. If you need a copy of the notes, I can email them to you.
Okay, we'll be glad to have
Please
that.
email them to us.
Yeah.
Thank you.
Use the provided email address system.
Okay.
Thank you all, and see you in August for the next webinar. Thank you so much.
Thank you. Have a good day, everybody. Bye-bye.
Thank you.
Thank you.
Bye.
Thank you.